talked about the importance of environmental health and availability of health hardware in management of otitis media and in primary prevention. So this last session we're going to focus on environmental health across the state and community. And so we're very lucky today to have Matt Lester from the Department of Health and Ray Christophers from Nirrumbuk Environmental Health and Services, who are going to provide an update on the current initiatives that are related to ear health and how they're progressing and what we can do so that we can really raise the awareness both within families but also within the service providers. So I think, Matt, you're going to start off. So welcome, Matt.
Ooh, okay. Oh, glasses. Here we go. Yeah, thanks very much. Firstly, I just want to acknowledge that I'm walking and talking on Wajak Noongar land and pay my respects to Elders past, present and emerging, and also to the many Aboriginal people around the room and from the many places that you're from. And also for every one of you who's actually interested in this work, as we are, in actually making a difference and certainly in closing the gap. My name's Matt. I'm from the Health Department. It's been my pleasure to work in environmental health for quite a few years. I'm going to introduce Ray, who most people won't need an introduction for, but he leads probably what I would say is the foremost or the best Aboriginal environmental health program that currently operates in Western Australia. For years, we've been referring to the Nirrumbuk model, and it's basically a legacy so far of what Ray has put into that. So my many thanks for that. And Ray's been working in this area for about 200 years, so he's got quite a lot more experience than me, and he's not shy in telling me where I go wrong. So we'll go on from here.
I'll just introduce myself.
Absolutely,
Okay.
please.
I just introduce myself first. Yes, I'm Ray Christophers. I'm the CEO of Nirrumbuk Environmental Health and Services. And first of all, I also acknowledge the traditional owners of this country, but also like to acknowledge my country is the Bari Jawi country, which is a couple of 100 kilometres away from Bream. I have worked in the environmental health program, I can say probably 25 years full time, and yes, it certainly has grown, and I do welcome the better health people coming on board with us, because it has been a hard struggle on the ground, being in environmental health, and now being a partner with health has moved us along, I think, in leaps and bounds. So I think from now on, things will get better in remote communities. Thank yous.
See, he gets a clap, you know, how good is that? Okay, so I'm just going to race through some of these slides just so that you've got an understanding, because environmental health is quite different to what I've had the pleasure of listening to today. In fact, I felt like a pretender in the room. I go, what the hell are they talking about? I do not understand some of these terms, but I'm sort of getting up to speed. Our interest in environmental health is the causal link between otitis media and the preventative management that we can apply through the home environment and modifying that. This is what the regulatory approach for environmental health broadly is. So you have an EHO in every local government in Western Australia, and they enforce legislation associated with those sort of things. Basically, the tap water you drink won't kill you. When you flush the toilet, it goes away magically to a, never land, and you're never going to see it again. That's what should happen. Health doesn't do those things, but it provides advice about how those things should be done to prevent people coming into contact with risk factors. The World Health Organization have the social determinants, the determinants of health. In the red, I've put in there just the physical environment, because that's where the environmental health is key here. I'm not taking away from education, but I'm just trying to highlight what are probably the more important ones from our particular workforce. Personal behaviour and coping skills is really important too, because it's the choices people make in their living environment that's just as important as what is provided. And I'll get to that a little bit later. And then, of course, the important one is access to health services, which everyone's trying to encourage more of. This is the programs, well, let's see, the Goldfields, Midwest, Pilbara, Kimberley. These are the areas where the program currently goes. It's funded to the tune of around about just over $8 million per year. All services are contracted by the health department. We have around about a 75% Aboriginal employment rate through those services. So the cultural safety of those services is strong. The training and retention, again, I'm referring to Ray's model here, but Nirrumbuk, we learned from Nirrumbuk about staff retention, which is one of the strongest factors that he's got. The map on the right is the Aboriginal communities and the outreach. So you can see there's an awful lot of communities. The red ones are the larger ones, the black are the smaller, but they're well clustered up in the Kimberley there. I guess I just wanted to refer here. So in environmental health, Aboriginal environmental health, we have two environments which we've traditionally worked in, one and not the other, and we're trying to migrate from one to the other. So we traditionally have done community environmental health, and now we're looking at how you actually work with people in their home environment to improve the conditions and prevent illness. It's primordial prevention. We have a roadmap for ear health, eye health, heart health, and kidney health. And we don't have a roadmap for environmental health, and yet it underlies everything there. Do you want to talk about that? Most of these shots are about your people. Oh, it's okay. Keep going. Okay. Actually, some of these photos, I've pulled them out from the library showing some of Ray's team actually in action there. But basically, the community environmental health is the dog desexing. You'll see a picture there. Plunging an outdoor drain to stop the blockage because the water comes back through the lowest drain point in the house. So you have a mixture of sewage and wastewater coming back into the house, which is not good. Slashing the grass is great for maintaining it and also preventing snake risks and all that sort of stuff. The picture on the right is what happens when a septic leaks and it goes outside of the house property. So that's black water. That's full of pathogens. And if you know anything about communities, a lot of people run around in bare feet. So you're essentially opening the opportunity for people to become ill. Plus dogs drink from that and transfer those pathogens possibly into the home. Solid waste management is one of the areas that we've traditionally been involved with, and yet we're sort of now getting a bit of negotiation with the Department of Communities to move away from the municipal service provision. Pesticide is the thing. So in the home environment, what we're really focusing on is a thing called the healthy living practices. These were invented around about the 1980s, 1990s by three key people. It was an Aboriginal elder, an architect and a doctor who came together to try and work out what a house needed to provide in order for people to live healthy lives. So what the health hardware in the home was that supported people's health. One of the things that they discovered in the Housing for Health, and you can see down there is more than 300,000 house visits and assessments that they've done over around about, I'd say, 30 years, is the belief that tenants are responsible for most of the damage in the home is a fallacy. It is actually the least cause of the health hardware that's dysfunctional. It's either improper health hardware that's been installed or it's not been maintained. And that maintenance is the direct responsibility of the housing organisations. When we look at the environmental health influence conditions, there's a lot of work that's been done with that. The Kimberley published their own analysis of this, plus the cost on the hospital system, which is called the KEEFs, Kimberley Environmental Attributable Fractions of Disease. But going just to in broad measures, the skin, the ear, nose, throat, upper respiratory, gastrointestinal, then the trauma from accidents and injuries, and then of course you've got eyes with trachoma and mosquito-borne diseases.
Just can I add?
Yes, please.
Just going back to what you see the photos of, those were the old service basically. We still do them, but we're moving now to what Matt's reading out sort of, and a more focus on that point. So that's where the health clinicians and all of that sort of come more into play. You probably didn't have a lot to do in here with this lot. We've managed to get service providers to be accountable more for that because we're on the ground to support this. The leakages, the block drains, yes, we still do them, but at the end of the day, we're making more accountable in housing departments, that sort of stuff. So we work with clients to get that to happen now, but we're still a backstop for it or the backup. And what we're trying to do with the whole program now is come to this point that Matt's starting on to give you where the future will go and how the environmental health gets supported for the next 50 years.
Thanks, Ray. One of the studies from New South Wales showed that there was a causal link between improving the conditions of the health hardware in the home just by maintenance, providing maintenance. They funded this program for, it says 10 years of health, but it's actually 20 years. They've been doing it for 20 years, only in certain types of communities, but they actually had the ability to, at the 10-year point, have a look and see what a sustained repair and maintenance program for these houses meant. And it meant a 40% reduction in hospital separations for infectious conditions. So respiratory conditions dropped 42%, skin by 20%, intestinal, and otitis media was pulled out as a one. Now, otitis media was a little bit interesting. I've circled it in red there because you'll see it's 0.66 and 0.58. So there was a reduction in both the cohorts of people who didn't have this service and the people who did receive this service, but they think that that's probably aligned to an intensive ear health program that was running simultaneously over that time, or possibly both. This is where it gets really interesting because we can look at hospital separation data and we can go, okay, you know, what's the burden of a disease, and let's see what we're looking at. If we look at these ones in red, these conditions are skin, ear, nose and throat, respiratory, infestation, gastrointestinal, eye. So let's accept that not all of them necessarily relate to the environment, but they are definitely, you know, a major component of that. I've highlighted in the yellow halo for a conference that I'm least able to talk about, which is the ENT. And so basically I go, well, whoa, bugger me sideways. There we go. Here it is. That is the second highest we've got here in clinic. So this was from a clinic, not from a hospital, but this is what the clinic's seeing. Now, this is old data that we extracted some time ago. So I was just looking at that. So the number 2 condition for people walking in, and this is all ages, was ENT. Now, of course, we're going, well, how much was E and how much was N and how much was T, which was my question. So recently, Aqua have allowed 6 clinic sites to provide data over a 12-month period. I'm presenting this information with Aqua's permission, and I'm not identifying the sites. I'm just going to say that they cover a good range of the state. But if you look here in the red area, which is the red bar, it's otitis media. In the 0 to 14-year age bracket, you can see it's equal number 2 with people presenting at the clinic after skin, which is the blue one, and it competes with unintentional injury, which is just accidents. And that number tends to diminish as the cohort gets older. But looking at that a slightly different way, the larger scale is the actual individuals, the percentage of individuals coming to the clinic to be treated, and you can see otitis media is sitting there at around about 32%, which is really interesting. When you go to the clinical items, they're actually the number of clinical services delivered, possibly to the same person repeatedly, or but it's just the clinical engagement. So again, it rates very highly. And I think that's quite a profound type of data to use. Other diseases beyond otitis media, which you might or might not be interested in, but I will bore you to death with, that we're really interested about is trachoma, is a blinding eye disease that people would be aware about. Australia's about to sign off to the elimination of that disease as a public health issue. It remains in some communities, and so there's going to be a steadfast effort to try and actually continue to work in those areas where we can't get the rates low. I can tell you now there are some communities with hyper-endemic rates, above 20% of the population. We're still trying to work with that. APSGN is a kidney disease which is related to skin infections, or rather related to group A streptococcal infections, whether they're acquired through a sore throat or the skin. ARF is similarly there. So if you're looking at the numbers there, that 97% of people on the register in Western Australia are Aboriginal, and it's an entirely preventable disease, as is APSGN. But these things set a person's health journey up, and they shorten lives. They really do. The last two are just interesting because scabies and impetigo are something that we don't really talk about because they don't threaten lives. But the rates of scabies that were determined from Telethon Kids in doing an analysis of, or a visit to communities in doing skin health checks over a period in the Pilbara and Kimberley, they rated the scabies at number 3 in the world, comparable, and the impetigo were at number 1 in the world. Now that is the pathway, impetigo is the pathway to ARF and APSGN. And that we must do something more about that. If that's impetigo, that's probably why your otitis media is also elevated. So similarly, infectious diseases are aging. Facial cleanliness is something that was developed for the trachoma program. So the trachoma program started funding some environmental health initiatives. A little bit of the funding to separate from the clinical screening that's done each year. If you look there, that the biggest thing that was identified by the head ophthalmologist leading the charge was its trachoma transmission is stopped by keeping every face clean. You know, it's that having that clean face type thing. It's that simple. It is a remote community disease. Health promotion that's been developed with the trachoma has actually incorporated the breathe-blow cough, which we talked about on the type C thing that was discussed. I was learning in the second. What's type C? Tell me what type C is. So the breathe-blow cough is just an NF. So that's basically, we went to the clinic, said, what are the general health messages to do each day that we could sort of, it could be that simple. So these stickers are applied in homes where we're actually doing the healthy home checks. And now I come to what the more important part of the discussion is, or the presentation, is the environment. We call them an environmental health referral form. We actually call them a clinic referral form, but that's confusing for clinicians because they make referrals for everything. So clinicians call them environmental health referral forms. It means that if a person presents in a clinic with a preventable contagious condition that the clinician believes is associated with the home environment or hygiene, they can generate a referral for a home visit by an Aboriginal environmental health team. Now, easy, sounds great, sounds wonderful, and that's it. Connecting those clinics with the services is really important. Having an understanding about what is an effective response is also important. And we've been particularly informed by work that was developed principally by Nirrumbuk right at its genesis about the process of getting clinicians trained, and then the turnover of clinicians in remote areas and in regional areas is huge. So as soon as you train one, the next person walks in. And also about what it is that an environmental health team can offer to a home and a resident in the home to actually improve the living conditions. This is a really simple way of describing what happens. And the other thing that our workforce can do is can do plumbing repairs. We are given an exemption from the Plumbers Licensing Board to conduct plumbing repairs. So you can fix taps, unblock drains, put new shower heads on, all that sort of stuff, fix a toilet if it's found there at the time. So you go to the family. I mean, that's a really simple way, and that we've moved on a long way from what this model is. But this, in a nutshell, is you either fix it or you refer it, fix it or refer it. Same as if the fix in the house requires a trade, like a hot water system, then you refer it to housing and they'll send out a plumber. I'm nearly done.
It's okay.
That's it? Are you all right?
Yep.
I touched on health hardware and health software before, and I'm just giving some images of the sort of things that can be seen in a home when you visit. The image on the left is the block sink. That can be fixed there and then on the spot, and it can make a difference between a living condition in a kitchen working and not working. The right-hand side is a house that we came across. The only thing that's particular, you won't see the kitchen in there. The kitchen cupboards were completely water damaged, and also the cockroach population in there was very, very, very large. You'll see that there's no curtains in the houses, so people make do by trying to put up blankets or anything because everyone wants their privacy. Also, the sink that you'll see there, the trough in the bottom left-hand corner was blocked for this young mum, and she needed help to get that. So we unblocked that trough. Or the team visiting on the day unblocked the trough. The toilet on the top is some clever architect designed a drop toilet to put inside a house. instead of a flushing toilet. The non-Aboriginal people living in the same community had given flushing toilets, but the Aboriginal people were given drop toilets. Well, guess what? The occupancy of 4 people was never ever going to be abided by, and that is basically the whole pit basically full up to the toilet entry there. The fork there is a classic. It's an old one. I apologise for the blurriness that the woman complained that a power kept shorting out, so her son fixed it by shoving a fork into the RCD. You just had to be careful around the sink; could occasionally shocked you, So, and then the knife into the hot water system there was the booster system. So it was a solar hot water system. Someone had chucked the knife in because they liked their hot water whenever they wanted it, So again, it's about just sort of these sort of things are common. I'm not trying to show you good or bad. It's just unusual things, that you sort of come across. This is fairly recent, so the fridge there is mould in the fridge. So obviously the seals weren't operated, which probably means that the food in there is not safe to eat. Again, it's not a judgment; it's just a case of, well, how do you work with it? Those in the home to actually improve that, because off food can really make you sick very quickly and very, very sick. And the right-hand one is just one of my favourites because I call them air conditioning art. And that is where people put their own air conditioners in because housing won't do it. And then there's no frames to support them, so they find something to build up a frame there. I'm going to finish there, but I just wanted to, I really want to hand over to Ray. I think there's an opportunity here. We've been working with Aqua to do a co-design of the program to move it away from the traditional work and to a future state which is more working with people in their homes and also connecting up with clinics. And
Go back to that slide.
which one do you want?
The cleaning one. Yeah, you've got to understand this a little bit when you look at fridges, air conditioners, the way they are, and you've got to think that you're 400 k's away from any service provider. So, yes, box air conditioners is what we use. Any form of putting it up is another way of doing it, but replacing fridges and washing machines, it's a task for anybody in any sort of remote area. So that is what we see. It's probably their way of how we get by with doing that, but the move, it's infrastructure and the use of the materials we have, it's normal really, but it's the volume of people that we have in these houses and the overcrowding. So if you can just think back on how would you do that? How could you adjust this to your normal and going back to a tradition? There is no refusal. People are allowed in houses. They share. They do what they want. And go back to the other one. And this sort of stuff just tells you that really at the end of the day, for me, it's the infrastructure is just not being checked on enough. There isn't enough services. And the amount of, I think, you can go to a normal sense of housing and you turn around and say, yes, we'll have maintenance looked at that house once a year. And some of the employment of housing staff is even hard. Like, I don't blame housing. They have the same difficulty as any of us to try and get people on board. So what Aboriginal people do, they improvise, they make it work. And that's sort of what they can do. How would you put a toilet like that in? Really, at the end of the day, I've seen those ones. I was there when they did, and they weren't whole homes. And it's just bad infrastructure or bad information given to whoever's building, and Aboriginal people then have to use it. And basically that's where we've sort of come out of it. I don't do a lot of dwell on it that much. I just more like, how do we live with it and how do we improve that? So we've come from that sort of world, and I'm hoping that with the new idea of housing, sinks and that, you've got to remember that even with a small environmental health team we've got right now, really for the amount of houses we have in the major areas, we're lucky to see them once a year, that house. So that repeat needs to really happen more regularly. And why we've progressed, as Matt's saying, to the future is health is bringing that awareness for us. Because as environmental health, we couldn't get it. We couldn't get people to understand that this needs to happen. You had to have a health problem for it to be recognised. And I'm so grateful for the CAMs, the AQUAs that's come on board and the region to have a look at this health problem and say, how do we help? Is that they've recognised it at the start, but it always got low priority. And really now we've progressed from what we've done this really because of the municipal servicing, the housing, the other chores got done. Some of the other chores are getting done. So now if environmental health can move to this stage where we really need to be. And talking about, if I can, the rheumatic heart and that sort of program, with the referral process, what we're hoping to do different is to set a program up and get data from it in the next couple of years to see if we went back to a house every month or every 2 months and guarantee the water was flowing, then maybe we can get some information out of that. But that takes a lot of effort and manpower to do that. And you're talking 200 and 300 kilometres away. We're time's up, are we? Nearly? That's okay.
Oh, no.
I'm as good as Matt for talking. No, but just to get you in the frame of it. So if you get a referral and you don't think it's working very well, bear with us because we are trying to look at the referral process, go back to that house where we got the referral from, try and have a look at it, but we're getting a lot of them in, but we're also trying to go to houses where we haven't got a referral for to ensure they're working okay, because we don't need another referral. So that's the sort of trying to fit in that schedule and build our workforce. And I think Kim talked about it the other day about how we're co-designing another state environmental health workforce. So as soon as that come on board, hopefully we'll have more numbers to be able to do that. And we're hoping that the referral pathway, we know it's the right way to go. It's just having enough people on board.
Yeah, that's right. Thanks, Ray. So I think just to reiterate here, we've got 5 minutes, here we go. So to reiterate here is the program, everyone we speak to saying if you could offer an environmental health visit to the home with people who were accepted by the people who lived in the home for a preventable illness to stop it either coming again to the same person or being spread within the family is a no-brainer. Everyone we speak to, you go, yeah, this is great, this is great. So the clinicians are on board. WACS believe it's good. Up in the Pilbara, WACS are even doing an experimental referral from ED, which is a great way to go. So we're not saying it shouldn't happen. Of course, the problem is when you get a referral in Perth because there's a limited capacity, there's no service here. So part of the other thing with the model of care and working with AQUA is to look over the horizon and imagine a world where the environmental health program applied across the whole state instead of the 4 health regions it currently applies to. And that means Perth Metro as well, all right? Because the need is great here, the population is great here. Southwest, the Great Southern, and the wheat belt. So they're areas that currently have no access to any of these type of services. And it doesn't need to be highly sophisticated. It's more part of that holistic wraparound parcel of offerings that the community-controlled sector is particularly good at managing and working with mainstream to actually deliver. So that's where a future is going, and I think I'll leave it there.
I'd like to mention too also that Wendy's contribution towards highlighting the fact of environmental health and us bringing it to the Department of Health as progressed this, and she'd managed to find the funds to be able to do a real workshop on it and to get all the environmental health providers out there to come together in the state. So I've got to say really thank you to her, and I think we can't really go backwards anywhere. We can only go forward, and whatever we get, it's always going to be better than where we were.
Is there any questions for Matt or Ray? That was obviously an eye-opening talk, so I'm sure there'll be some
child health from SWAMS. Just wondering about your referral. So do you service the whole state?
No.
Or no?
We've spoken to Leslie about providing a service at SWAMS. Yep. In a future state.
Yeah.
Yeah.
And I think because I sit on the Aqua board also, and I think that like SWAMS and bigger towns, I think it's a different approach, but there is an approach. It's not exactly the same as what you might get in the Kimberley, but I think we have to develop an approach where it's believed you have the services, but we know that's not true. So we've got to work out a way how we can do that. Yep.
Seems like it's better off being closer to the metro area, but because of that reason, but sometimes it's actually better being further away.
No, we know that's not true, and Vicky, the chair of Aqua, has really pushed that home, that the metropolitan area and some of our bigger towns that in the past, because you got to, like I said, the past of environmental health was the tractor, the rubbish tip. Well, you didn't really get a lot of that in the metro area. But today, where we're going to with the preventative health stuff we need to do, then we're well and truly in it.
Yeah.
And we do need to fix it.
Andrew Van Ballagorn, GP Calabaran. You raise the issue of air conditioning. Most people here, well, particularly in the wheat belt, it gets really cold in winter, it gets really hot in the summer, yet Homes West will not put air conditioners in the housing. I mean, I wouldn't live in that environment without heating or cooling, yet we expect that other people to, and they all work in their air-conditioned offices.
No.
We agree.
No, and that's true, and same for the remote communities. We have lobbied housing to see if it can be part of the fit out of a house. Some of the parts of the Kimberley, they have done that, but a lot of the new areas, and I think it's just something that will come with climate change, I believe.
I'll mention, I'm going to say something a bit naughty, so I got asked whether or not we had any initiatives for green energy and that sort of stuff. So, and I just said, well, why don't we just put air conditioning in the 3,000 State West homes that are across the state? So we put in a submission like that. We costed it out, and we thought, okay, and we'll have people who might service them, you know, so that they're looked after and see what we do. So we think we costed it out, and anyhow, look, it was a stab in the dark. You know, we had no idea if it was going to get up because we were appealing to another government department, and it wasn't on their agenda, you know. Anyhow, my colleague Rob nominated tree planting as an important thing for providing shade and natural shade and you know, possibly even growing fruit and all that sort of stuff. But you know, trees and anyhow, his suggestion got up and they loved it. That was great. So the tree planting was a really good one. And then someone went, oh, hang on. No. Why don't we do the air conditioning? We can do the air conditioning. Anyhow, so it was sort of touch and go. I costed it out at around about 10 million. 10 million, which you could introduce over 4 years. You could roll it out, and you could also roll out a workforce to provide servicing for that. It might just be cleaning and servicing. And it got, no, it's ridiculous. And it got poo-pooed. And as soon as it got struck off, a week later, the Roburn prison was offered air conditioning at 14 million. And I just went, wow, okay, we just missed out on air conditioning, you know, all these homes, but we'll do the prison, a single prison. So anyhow, I mean, that's a very naive approach from me because there's obviously costs with installing and all that sort of stuff. But we thought we'd factored that in, but it is on the agenda, believe me. So they are looking not only with air conditioning, they're looking at sustainability measures, so improving the efficiency of the house to actually adapt to air conditioning, so the running charge is not so expensive, and also putting solar panels and batteries, as long as these batteries stop exploding, you know, and causing fire. So.
Hi, I'm Brianna. I work for the Child and Adolescent Health Service in the metro area. So just wondering, thanks for sharing, because I was really looking forward to this talk. Something that came out of last year's forum, I think, of let's get environmental health involved. So for those of us who work in the metro, any tips for where we can sort of start to bring up these issues and raise flags or whatever? Like, any tips for us?
Every discussion you have with every person you have.
Well, look, I think you can't go past having a yarn. And really, at the end of the day, because of environmental health, I got into different state department contracts, and one of them is the Thrive program that we do. And generally, it is a conversation. It is a conversation about how do you change your life and how do you look at it differently. And then it's talking about who out there is available to be able to help you. And you'll be surprised on who you find. And amongst our contracts that we do, there are a number of areas that can help if they have access to it. And that's the thing, like generally in a house, you've either got a pensioner, aged care, or somebody that's probably living in housing conditions that you can probably ask for change. But I think every service provider really wants the tenants to think about what is it that they're going to do different. And I think we started with a chair, go to the house, pull up, sit under a tree or the veranda and have a conversation.
Yeah, I just want to also, I'll go back to what we talked about right at the beginning. This is a non-regulatory program. All right, if I had my regulatory hat on in environmental health, because I'm involved with designing regulations for public health, eviction would be your only solution in many of these instances, and that's just not tolerated. It cannot be in this place. So it's about working with people, even with overcrowding. I know I had a discussion with someone before. It's about giving strategies for managing overcrowding, and hope that that's a temporary thing. It's about making sure the health hardware is more durable so that it can have those extra people in the home using the services, that sort of thing. So.
When I was listening to Yusmob talking about housing and stuff like that, I just wanted to share a story with you about our outstation, Jimalagadunj, which is about 120 k's outside of Derby heading towards Fitzroy. Our house, you know the sides, the stuff they make for freezers? That's what our house is made of. That's why we put air conditioning in there, because it is so horrible trying to live in that hot house. And that's what some of our people have to face. I must say that the houses built now aren't made out of that same material. But that's one of the other reasons we put air cons in our houses too, because they're made out of that same stuff that they make freezers out of. That's our walls. And on a good note, I've done referrals to environmental health in Derby, and I've been really happy with the success of their work with my clients.
Great. Thank you. Just going back to the housing, I don't know, we're probably going over time, and I apologise for that. Department of Communities recently they've got a draft Indigenous Aboriginal community housing guide, which was developed by an architect who'd been doing a bit of room to breathe work up in the Northern Territory, and was inspiring people to think a little bit differently, including about what materials new houses should be made of so that they're more efficient, including any house with 2 bedrooms or more gets 2 bathrooms, because that's a no-brainer, so that you can have different generations living in a house. All this sort of stuff. So very exciting. I presented at some of those ideas in May at a national conference, but I said I'm only going to present on these ideas if you will intend to use this guide. If the intention is to use the guide, and I was assured yes. Now they haven't released it yet, but it's an amazing piece of work, and it might change the way we've done construction in the past. So you're absolutely right.
I just add to that, and I think it's a good move towards it, that across the state you got to remember that Horizon has taken over a lot of the power generated to houses, and that's one of the first things they started talking about, whether the homes were insulated or not. So they are going there. Yes, the steel cladding, the mini orb that they put around houses. Look, we're trying to find out from housing just what houses are insulated and which ones are not, and that's a big enough job. But you've got state government now looking at the water and the power as the different utilities. So I think the insulation will improve, whether it comes from housing or come from your power source. They are definitely looking at how they can save on power generated.
Last question.
Thank you both for the chat. That was great. I just want to know if there's any parallel programs running in different states, sort of specifically NT or SA.
I've got to say, this state, we're lucky because some of the other parts of our country, they're really poor in the environmental health support. And like I say, 15, 20 years when I started, but 15 years we knew we had to make a push towards the health service to help us. Because generally out there, and I'd be fair to say that, Matt, that a lot of the people we meet at conferences, there's less and less across the country. They're now looking at it. It's now the voice of Nacho and the hierarchy, I suppose, of this country, that they are really talking seriously about environmental health. So I am hoping that across the country, environmental health will improve. Environmental health training, there is nobody really delivering that program. We've started to look at how we can improve that, and we're getting demands from across Australia really to come and be able to show a model that can work.
Yeah, every time we have a national conference and a WA presenter talks about their part of the program, they're just overwhelmed by the envy that comes from many other states going, my God, how do we get something like that? Even Queensland, which has a partial, funded to about half the extent of what WA has. So there's some good things. There's some good things to build on, but it's not adequate by a long shot. And that's, it's how many you've got on your team for the Kimberley?
What do you mean?
Well, people.
Yep. Oh no, they're all old.
All right, well, the retirees.
The retirees, yes.
But less than 10 is what we're talking about. We're looking at regions. I was lucky enough to go to Tom Price to do a combined a couple of community work. We did that in Tom Price and in Onslow, and all the environmental health, Aboriginal environmental health workers gathered to do a common visit to the community, all 7 of them for the Pilbara. So, yeah, it's not enough. Yeah.
Fantastic. Okay, well, that's really drawn a lot of interesting pictures. I think tonight we're going to